esophagus and where's the stomach. And so you see it beautifully highlighted where this is esophageal tissue, this is gastric tissue. Here's another dye that you can see where you can see the segment of Barrett's lit up with this blue dye, and then this is all normal tissue. And then this is magnification where you can actually see the glands just by pressing a simple button and see the normal versus abnormal tissue. So what we're looking at here is millimeters in size. So here's another example. This is our traditional, what's called white light endoscopy, what we do every day. And then we press a simple button, and now you're seeing beautiful mosaic patterns of glands. And then here's another concept of what's called autofluorescence, where we inject a dye, and we can see abnormal cells versus normal cells. And this is something called confocal microendoscopy. What this is we take a little probe right through our scope. We put it on a piece of tissue, and it's like we took a biopsy, stained it, and looked under the microscope. So what this allows us to do, it's like getting a real-time specimen without ever getting a biopsy. And it gives us such great detail that we can actually now pinpoint the exact area that we need to biopsy. So this is being applied in the esophagus, it's being applied in the colon, it's being applied in the bile duct. And I think that this is really the future of how we're going to diagnose early cancer in the GI tract. And again, those of you who have never looked at a slide under a microscope can still tell me that this looks very organized and looks very nice and neat, whereas this doesn't look neat. It looks very disarrayed and very disorganized. So that is actually an example of an esophageal cancer. So then the next question is we talked about screening, is surveillance. So once you find Barrett's, what's the protocol? Well, again, the definition is ongoing investigation in a high-risk population with the goal of early detection of advanced dysplasia or cancer. So one of the debates among endoscopists is, well, do you biopsy every 1 centimeter or do you go every 2 centimeters? Well, time is always money, and unfortunately, most endoscopists are always rushing. So you really want to go to someone who does a lot of Barrett's disease and takes their time doing Barrett's biopsies, because it is the number one thing that will lead to accurate diagnosis. One study showed that biopsying at 2 centimeters missed 50% of cancers, as you would expect, as opposed to biopsying at 1 centimeter intervals. So this is put out by our society, the American Journal of Gastroenterology. These are our guidelines. So if you have a patient who has Barrett's but has no dysplasia, they should have at least 2 endoscopies that document they have no dysplasia. And then they can be surveyed every 3 years. If you have someone that has low-grade dysplasia, you should repeat it and make sure that there's no higher-grade dysplasia, and then survey them every year. And then if you have high-grade dysplasia, you repeat the endoscopy because you need 2 pathologists to confirm this. Now these guidelines were put out in 2002, and really this whole paradigm has changed. And I'll talk about why towards the end of this talk. So again, what's the rate of progression? You have high-grade dysplasia to cancer. Well, it's very variable. One study found 12%, another study found almost 60%. And then what's the progression from low-grade dysplasia, or IND is indefinite for dysplasia, to high-grade dysplasia of cancer? Well, again, 7 to 30%. So, again, in this study, 5 centers found 7% of patients with low-grade dysplasia and 2% of patients with no dysplasia developed cancer. In these studies that were ranging from about 2.7 to 7 years. And then this was one of the largest studies that looked at almost 1,400 patients with Barrett's, and found that 91 patients had cancer at their initial endoscopy, which is a fairly high number, almost 7%. 3.5% developed high-grade dysplasia, and about 2% developed cancer. And in those patients with high-grade dysplasia, this is the interesting statistic, that in their subsequent studies, they had no dysplasia. So this is why it creates so much confusion, because just because you have high-grade dysplasia, it doesn't mean you're going to get cancer, and doesn't mean that you're going to progress to cancer.
So what makes dysplasia go away?
Well, it's a great question. So the question is does acid treatment make it go away, or is it that when you took that biopsy of that area, you removed that area of high risk? And is it sampling? I think more and more that's what we're believing, that when we do these, we're basically removing that mucosal piece that had dysplasia. So again, obviously we know that surveillance leads to early stage of diagnosis of cancer and therefore prolonged survival. So again, here are some of the arguments that I've outlined. There's relatively small number of cases per year of esophageal cancer. You would obviously have to screen a very large percentage of the population. Less than 10% of patients with esophageal adenocarcinoma were diagnosed with Barrett's surveillance. So again, 90% of patients that we're finding for esophageal cancer are because they're symptomatic or they have some other reason. Up to 40% of patients with esophageal cancer may not even have GERD symptoms. So who do you choose is the other part of this. So I think, the bottom line is that I think it may be effective in screening Caucasian males over the age of 50 who have chronic reflux symptoms. I think that's a good index population to target. And I think that obviously surveillance should be limited to those patients that have true dysplasia. So majority of your patients may have Barrett's but never have dysplasia. Well, are you going to keep surveying them? If you have a 30-year-old for the next 50 years, obviously that can be very costly and may not be of the greatest benefit. So that leads me sort of to the last part of this talk, which is, okay, so we find Barrett's. Well, what can we do about it? Well, I think this gets back to why maybe screening should be done. Because it's one thing to have a screening test and say to a person, well, you have Barrett's, but your options now are really not that great. And the reason they're not that great is that traditionally, removing part of the esophagus is a very morbid operation. So it's not like taking out your gallbladder, your appendix, or even taking out the colon. The morbidity, even in the best centers in America or all over the world, is still about 15% of a complication. And mortality is about 5%. So the paradigm shift that I even see now from surgeons is, well, what can you do for me with the scope? And that is very exciting for a gastroenterologist who's interested in sort of the advanced areas that this field has gone into. And I'm going to sort of highlight some of the things that we're doing here at GBMC for this. So traditionally the concept was, well, okay, you have Barrett's, and the Barrett's really isn't that deep. Can't we just burn that tissue and get rid of it? So, we have these, what's called an argon laser that we use traditionally for coagulation. People have tried using that for Barrett's ablation. We have other heater probes, we have other lasers. The problem with all these techniques is that it doesn't get deep enough and it can lead to other complications. So these last 4 techniques that have come out have really revolutionized how we're able to get rid of